All right. So very excited to be here with you guys today. I really love looking at this test and seeing how it moves us forward into in patient care. Big fan of stool testing and this test in particular. And so often when I'm working with people and maybe they have hit a wall with a patient, they're not sure where to go yet. I often say, have you done stool testing? And the answer is usually yes with our more complicated patients. That's often the case. And we'll go over what was seen there, maybe something dysbiotic, a low secretory IgA, abnormalities in short chain fatty acids. And I'll ask the question, well, did you do a follow-up test? Do we know that these things are resolved? And so often in those complicated cases, it is going back to the gut and seeing where we're at and making sure that those abnormalities that have resolved themselves to push us forward. So I love working with this test because I think that there's so much that we can glean from it, and it really helps to pull together for our patients why the gut is so connected to everything. Well, maybe everything, but almost everything out there that we wish to treat in terms of chronic disease. I love to be able to take that moment and to talk to patients about, look at this short chain fatty acid. For example, acetate, really good research in terms of cardiovascular data can be a reason that helps to prevent LDL from being oxidized in the first place. So this is why we need to think about the gut. This is why we need to increase fiber for your cholesterol that's elevated, and really being able to make those connections that tie gut-based pathology to what's going on in the patient. And the more and more I learn about markers that we look at in the gut, the more and more I'm reminded of their importance. So I used to possibly make the mistake in terms of maybe having that patient with severe autoimmune condition, maybe a Crohn's patient, and then and they explain that this happened after they got food poisoning a number of years ago, and so something we're already like from the history figuring out something disrupted the microbiome. Okay, there was probably some type of pathogen. We're going to do this stool test. We're going to see this pathogen. We're going to treat it. We're going to calm down an overactive immune system, and we'll be able to put this autoimmunity into remission. And then you get the stool test back and you go, oh, there's nothing really dysbiotic here. There's not a lot of bad bacteria. There's not necessarily a parasite. Maybe there's a little bit of yeast +1 or so. I guess this test didn't tell me what I needed it to tell me. But if we go through the good, healthy flora, if we look at things like bifidobacter and lactobacillus and see those having practically no growth or a very low level of growth, that enough will put us on an inflammatory trajectory, even in the absence of pathogens. If we look at short chain fatty acids and we see they're low, they're directly anti-inflammatory in the gut. Some research suggests that healthy levels of short chain fatty acids can even be as calming as something as prednisone, but without side effects there. So in the absence of pathogen, if I see low short chain fatty acids, that is enough to create the pathology. If I see a low secretory IgA, 85% of what should make up immune function, again, this too can be enough for a reason somebody is having symptoms. So when you order a stool test and you don't see that pathogen that you wanted to treat and nail and put everything into remission, don't be dismayed. There's so much information on there that can explain inflammatory pathways in our patients. And we're going to dig into that and really think about how to get the most of what we're looking at. And the timing, I suppose, couldn't be better because I think just the New York Times the other day showed a cool little demographic map in terms of populations over 65. And by another 10 years, Japan's going to have a huge number of percent of their population over 65, followed by a lot of Europe. We're not far behind. And so not only, as this article pointed out, does it mean that we have less working class, we've got to think about about that. But it also means that we're, of course, going to have more chronic conditions. And we know that so much inflammation can start in the gut, and particularly when we're thinking about an aging patient, there's a lot going on here that we should be mindful of. And so just the mere act of digestion begins to get compromised. As we know, we don't produce the same level of hydrochloric acid. We don't produce the same level of digestive enzymes. This can mean that we don't feel as hungry, or if there is a little bit of bacteria on some food, we're less likely to have an inflammatory event from it because our normal level of enzymes aren't there to kill it off and to deal with it. And we've all, witnessed this. We take our little old great aunt out to eat, and she, of course, suggests something that we would never think of, some giant buffet, but okay, so we go there and we sit down, and then we watch her, pick at 3 bites of food and finally settle on 4 bites of key lime pie. And then you're like, oh my gosh, what is the point of even being here? But yes, we know there are a lot of reasons that as we age, what we eat changed, how we interface with it changed, who is cooking for us, our access to things that are more nutrition, our sense of taste changing. So a lot of uphill battle in terms of keeping a well-oiled microbiome. And I really love this schematic because it very much demonstrates, I think, as a potential pattern. And so what we're looking at here are people who age and who age in a healthy way, but then also those who make it to be centenarians. And so that means you made it over 100. And it tracks what happens with the microbiome as this is going on. So what we see over here in our healthy adult is very little opportunistic bacteria, a lot of what we would consider some of our more healthy flora, families where, for example, Bifidobacter hangs out, and a relative diversity, abundance of good, healthy flora as well. So now we're older. And so what you see is that up top, this inflammation meter has increased, but yet you're still a healthy adult. And so what we see is there's an increase in this opportunistic bacteria. If we dig into our family where Bifidobacter hangs out, we see there's a decrease in diversity here, and that kind of goes across the board for families that we consider beneficial. But if you happen to make it to greater than 100, in fact, you're experiencing less inflammation. And so when we track through what's going down, what we see is this opportunistic bacteria is the same as it was in more of a healthy adult. The diversity and the amount of things like Bifidobacter have remained consistent as well, and diversity in general. And so I think back to when I was doing my residency at cancer treatment centers, and people would come in and they would say things like, oh, well, I read I need to do a parasite cleanse to keep my immune system healthy. And to me, that didn't seem very grounded in exact science or data. To me, it seemed maybe not directly related to what was going on in front of them. And then people would do various botanicals, was often the next step there. Botanicals that contain berberine, or maybe something like artemisia that does have some anti-cancer research, but also pretty potent antimicrobial as well. And they would do these things and they would note feeling better, or we would see some improvements overall. And I was always left scratching my head because, I wasn't really of the mindset that, oh yeah, there was some parasite, this eradicated the parasite, and ergo, that's why one is better now. But as I look at schematics like this, I began to think that my dismissal was a degree naive for sure. And the reason that I come to that conclusion is because when we think of those botanicals, often labeled antiparasitic, they're also antimicrobial, antifungal. They're broad spectrum. And when we look at what's going on here and then think about the idea, if somebody does a course of some botanicals that are antimicrobial for a period of time, really knocking down this opportunistic bacteria, a result is to allow for more diversity in families that are so important to us. And so I fast forward to my next, I'm sure not my next, but my next relevant piece of skepticism along the way. And I think about when things like berberine containing botanicals first began to be more popular for things like metabolic syndrome. And so things like our Oregon grape or our golden seal, our Coptis, botanicals that have berberine in them. I'm very familiar with these because to me, berberine containing botanicals are your go-to as your natural antibiotic. You even see sensitivity for this on a stool test demonstrating that it's one of the ones that we know is generally most effective in terms of dealing with potential pathogens. And so seeing these show up in metabolic formulas, something that you might take for diabetes, was concerning to me. The data was very good. I was impressed with that piece of it. But in my mind, I thought, well, if it's a natural antibiotic, don't we risk compromising the microbiome if you stay on it more long term to manage something like a blood sugar issue? And so initially I was not a fan, but as the data came forward, what we saw was that things like berberine are actually sparing of our natural microbiome. And at this point, we don't just have one study, but we at least have a handful of studies that corroborate this idea. In addition to that, what we see when we look at the aging data, when we look at what happens with someone who is aging more rapidly or more frail, we see that their microbiome is aging as well. So fascinating studies that look at people from all over the world, from Spain, from France, from the United Kingdom, and the hypothesis of the study is where you live will dictate your microbiome because the food we eat has the bugs. That's where we're getting inoculated from. So similar terrains should develop similar internal terrain. Well, as it turns out, well, that is a factor when we see the microbiomes that most resemble each other. It doesn't have to do with where you live, but how healthy you are. And so if I'm a frail 80-year-old and a frail 21-year-old, my microbiome looks very similar. If I'm a healthy, robust 75-year-old or a healthy, robust 35-year-old, that microbiome looks very similar. And so we began to learn from studies like this, changes in the microbiome drive what's happening in terms of aging. And I always love to okay, so that's a trend. As the microbiome changes, we see more chronic conditions. That's interesting, but does it matter? So in these studies, then they went back to give probiotics and monitor the microbiome. And you did see a shift in certain flora. We're going to look at that, things like Bifidobacter and Akkermansia. And as those increased, you saw a decrease in chronic conditions, inflammatory conditions. And so again, what this tells us is not only that as our microbiome ages, we age, but that we can treat it and that it's meaningful. So what I was mentioning in that story was that this use of berberines for diabetics initially concerned me because I wondered, are we going to just kill off our own good, healthy flora as a conventional antibiotic will do? And what the research says is no. And then what the research further says is why. And the reason for that is one of the major things that our berberine containing formulas do, one of the major things that anti-parasitic formulas do is they're broad spectrum antimicrobial. And when you kick back at this opportunistic bacteria, you're like weeding a garden. You allow more room for good healthy flora to grow. And the stronger our healthy flora is, the less aging we have in general. And so these strategies that I initially blew off as being less than evidence-based, I think really do have a definable mechanism of action. The name might not be quite right, parasite cleanse, but the idea is. And so when we use these microbials to kick back at things that are dysbiosis, we're decreasing the trajectory of chronic conditions. So all of that's well and good, but how do I use it? And so for me, memorizing the names of a lot of bugs, and this one is elevated, and so therefore I should do this, can often become quite confusing and probably a little more specific than really the data warrants at this point. But when in general, when we're looking here in terms of our families of bacteria, what you want to see is nothing pulled too far to one direction or another. We're really looking for that diversity, so not seeing anything pulled out into the red. Now, if you want my quick mnemonic in terms of which areas I think are a little more beneficial, really from over here at 1 to 7 o'clock, if I see things pulled out a little bit more in this direction, those tend to be areas that are associated with less aging, so I'm not as worried about that. And so some of these areas can be a little more associated with inflammation. Again, those are broad strokes. We're going to drill down on some specifics there. But in general, what you want to see is good diversity between those areas. So when we look at what happens as we age, it is unrealistic to expect that you're going to have the same gut that you had when you were 18. And so, when we come onto this planet, we are lacking in bifidobacter, right? If I said to you, what is your number one go-to probiotic for kids under the age of 2, you'd go, ding, what is bifidobacter? And you would be right. And so, but it's interesting, the same one that we're lacking as we come onto this planet, we begin to lack as we leave this planet. And so we begin to see less and less bifidobacter, and that can be associated with more aging in general. And so as we age, we tend to move towards either group 2 or group 3 as an overall compilation of species that you'll see. And if you eyeball group 2, you're probably going to see, okay, yeah, a little more commensal, maybe pathogenic bacteria, things that we'd be less likely to want to see, versus group 3, okay, things that tend to sound more favorable overall. And you would be right. We want to move towards group 3. So healthy aging is associated with either, maintaining as much of our bifidobacter for as long as we can, or moving into this group 3 in terms of more Akkermansia. And so as you can see up here at top, unhealthy aging, things that are associated with a inflammatory microbiome, from cognitive decline to cardiovascular disease, obesity, being on more medications, osteoporosis, all of these things that we associate with aging shift as we move towards this more inflammatory group. So again, some of these kind of eclectic practices of using antimicrobial botanicals as a detox, I think, are things that knock down a lot of the dysbiotic bacteria, the anaerobes that form LPS. And so LPS is that lipopolysaccharide. It's that bacterial endotoxin. As we age, the gut becomes a little more permeable. You start to see more dysbiotic or even commensal flora that makes higher levels of LPS. It begins to leak through intact, and that's that bacterial endotoxin. And that endotoxin can damage a lot of things. It can damage LDL, creating more oxidized LDL. It can just damage the heart itself. It moves across the blood-brain barrier, can be responsible for things like depression or cognitive decline. And when we see this endotoxin, of course, can also be harmful in terms of, well, the liver has to deal with it. When LPS moves, it goes right from the portal vein, boom, dumped straight on the liver. And the effect that it has there is it creates inflammation. And so the liver's response is to increase its production of things like cholesterol or triglycerides. And so we begin to see how gut-based endotoxemia is directly related to so many conditions of aging. And so good models that really help us to understand this more are these things that look at an aging gut, a young gut, and things like fecal transplant, where we take the microbiome from young mice and we put it into an older mice, and then you watch what happens in the older mice in terms of cognitive behavior, and you see that the older mouse, when it gets the young microbiome, the part of the brain called the hippocampus begins to plump up, resulting in more learning and memory. And he becomes physically and chemically similar to the younger mice. And so they get these microbiome poop transplants, and they navigate the mazes faster, and they remember the layouts better. And so those who don't get the microbiome upgrade do not have this kind of youthful reversal of time. And so we began to see these good models that point to when you change the bacteria, how it changes what happens in terms of aging. And so as we look at this, I think it becomes useful to think about which species are these keynote species, which species are really highly substantiated in the research. Where do we want our eyeball to go on the stool test to see, okay, how inflammatory is a person? And so one of those species that's really important to me is the fecal bacterium prunensis. And we're going to see something interesting about it when we look at it on the stool test that indicates how beneficial it is. And so this is an example of, if this is low, just the beneficial flora being low means that you aren't going to make the same level of anti-inflammatory peptides or things like salicylic acid. You're not going to be producing this quorum sensing molecule that tones down inflammation in the gut. And so again, there's that autoimmune patient. You just knew there was going to be something dysbiotic. They also often have loose stools. You get it back. You don't see something dysbiotic, but you do see this beneficial flora to the low end. That is a reason enough that they are having plenty of inflammatory issues in terms of the GI tract. And so, like I said, when we think about, cleanses, or when we think about, strategies to increase the microbiome, this means that what we're doing is we're improving the crosstalk and between, commensal microorganisms and also our own immune system, innate lymphoid cells. And so when you start to have a lot of dysbiosis, and it's, more commensal, but this ruminococcus, it's very much associated with allergic disease. So when we see this show up on our stool testing, we think, more histamine. And not only is it more histamine producing, but it's directly activating these innate lymphoid cells. And so as you do that, you become more and more reactive to things, more and more responsive to things out there. So for example, the patient who you've run a food sensitivity test on, you took the foods out. They were really religious about it. They did everything that you said to do. And now you're going to do a challenge. You're going to have them eat a little bit of the food, and then you're going to repeat the test. And they come back and their titers are just as high as they were before. What do we do at that point? Well, often your next best answer, let's say even you did the food test, you took the foods out, they still seem very reactive. The next step there, probably your next best step isn't to repeat a food test, it's to do a stool test, because so much of how we react to foods has to do with the flora in the gut. And so when we normalize the microbiome, when we even help kill off things that are commensal, it means that our immune system will be less reactive to foods. And so the whole point of doing some food sensitivity test is not to take somebody off foods for the rest of their lives. It's to do it for a trial, for a period of time, to heal that gut lining and to allow the microbiome to reestablish itself. And this study, I think it's in here later, but this blows me away. Okay, so they did desensitize kiddos who had reactions, IgE reactions to peanuts, immediate reactions, and they gave them desensitization injections. And one group got lactobacillus and one group didn't. 4 years later, if you got desensitization plus lactobacillus, 84% of that group was still able to tolerate peanut. If you only got the desensitization, only 4% of that group was able to tolerate peanut 4 years later. So what does that tell you? Removal is one way to desensitize and working on the gut. Desensitization can also be done through injections or sublingual immunotherapy. We'll talk about some of the similarities there. But when it was combined with shifting the microbiome and with just one probiotic, think if we were actually looking at somebody's microbiome, individualizing, making sure that you got that much more clinical response. So I think when we're dealing with that person who's highly reactive to everything, they struggle with every food they eat, it's often so important to go back to the stool test and look at what's happening in terms of the microbiome, because this is how we're going to calm down the immune system. Food removal is a start for sure, but ultimately I want you to pull those foods back in, not like tons of gluten and dairy, but when they come back reactive to spinach and tomato and cucumber and blueberries and all those things that make a beautiful, diverse, phytonutrient rich diet, yeah, we want to bring those back in. That's the goal. And so we can go look at even some of our commensal or healthy bacteria. So here's that ruminococcus, and if it's elevated, we know that that gulch, that lymph tissue right there in the gut lining is going to be more irritated, more reactive. And so working to help put things back in balance. What would we do at that point? Is it that we're trying to kill it off? No, not exactly. I think in a case like this is where you'd introduce more beneficial flora to compete with it, to more normalize the microbiome. When I got started with these things at first, and I still do a lot of this because I'm just curious, but at first it would be a lot of, ooh, look up this exact bug and see exactly the pathologies it's tied to and see if it's exactly what's going on in the patient and dot, 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 dot. And of course, we want to be as evidence-based as possible. But in general, even if you don't know the bacteria, know the name, even if you don't know its top 3 most important identifying characteristics to it, that's okay. But we want to see balance here. We don't want to see anything too high or too low. And I know that sounds vague and possibly even sloppy, but in general, that's what we want with our gut-based approaches. We want good diversity. And if something's way out of balance, even if you don't have 12 footnotes about it, I would say, okay, that's not how a normal gut is. You're having symptoms that aren't normal. Let's work on balancing here. We'll probably see positive outcomes with that. So then here's the fecal bacterium pneumonia that I was mentioning, that I was saying is so beneficial. And I really wanted to show you, okay, yeah, this is what they look like on your stool tests to get them in your memory. Because for me, just reading about them, but oh yeah, clinically, how am I going to use it? That's what locks it in for me. So here it is. And that's what it looks like. But then notice, of all the bacteria, and these are good, healthy flora, all these are, but again, we want balance. This is one that does not have an upper range. Why? Because it's so anti-inflammatory. It's really unique. So let's say you had no pathogen, but you had a lot of the ruminococcus, and you had no fecal bacterium. That is enough for a highly inflamed gut. There's, there's no need to say, oh my gosh, I wonder if this sat in the sun for 7 days and didn't get there in time. These aren't the results I was expecting. That those are results enough that are highly treatable. So, and then also here's another species that can be responsible for making more histamine. So when we see this high as well, this is another that would play into that we would think about what's going on there. So if fecal bacterium is so beneficial, what can we do to influence it. And well, one thing is prebiotics, and we're going to see a slide talks about blueberries. So probably right now you're doing a lot for your good anti-inflammatory flora. Here in Georgia, we're in height of season for blueberries. Just got my flat from my organic co-op that I like. So anything good blueberries do for me, I am there in full swing right now. So increasing this species, reduction of colitis, improving the gut intolerances. And so some of the things it does increases alpha ketoglutarate. Oh, right. Intermediate in the citric acid cycle associated with better energy production, that connection between gut-based changes and fatigue, increases peptoids like raffinose. Oh, this one helps to downregulate a Th2 and more of an atopic response in the immune system, increases the anti-inflammatory shikimic pathway. Oh, well, humans don't have that. Why do I care? True, we don't, but your bacteria do. And this is in fact, this is the reason that it was said, oh yeah, glyphosate won't be bad for you. It just acts on this pathway, the shikimic pathway, and humans don't have it, so humans should be fine. Okay, well, number one, it acts on a pathway that's very important for bacteria. Bacteria use this pathway to increase, to take amino acids and the aromatic amino acids and convert them into more of our neurotransmitters, things like dopamine and serotonin. So glyphosate interferes with this, changing those neurotransmitters that we make in the gut and communicate along efferent, along vagal nerve pathway. So that sounds like a problem to me. Second of all, just because we don't have this pathway, to suggest that glyphosate doesn't interact with any of our enzymes in our body is really bold. I mean, any cytochrome P450, anyone? Like everything gets detoxed through those, glyphosate as well. So yeah, it does turn out that it inhibits that 1A1 pathway, and that's the one that helps with more healthy estrogen metabolism, so increasing risk of breast cancers as well, but really wreaking havoc in terms of our bacteria. So organic foods will increase your fecal bacterium as well. Right now, we're all inundated with the idea of GLP-1 agonists and the Ozempics and the semaglutides to lose weight, to lose weight, to lose weight. And while I think that there can absolutely be some benefit there, I think nobody is suggesting, nobody is probably saying, yep, I want my patient on a semaglutide inhibitor for weight loss for the rest of their life, right? We're probably saying, let's use it short term to get some weight off, to teach healthy eating, use it in a manner like that. Or you're wanting to say, are there some natural alternatives? Well, this is an important time to turn to that short chain fatty acid section with your patient and remind them that one of our best ways to increase GLP-1, that thing that makes us feel more full, is an increased production in our short chain fatty acids. So when we're thinking about, for example, natural alternatives here, or when we're trying to figure out why somebody's weight loss resistant, and again, let's just say you look at their beneficial flora and they've got really good levels. There's no problem with bifidobacter. There's no problem with lactobacillus. Everything's growing just like it should. But now you go to short chain fatty acids and they're low. Then I would say, even though compared to other people, the amount of colonies being grown in that person are normal, it's not enough for them. Short chain fatty acids can kind of serve as a functional marker for is our good healthy bacteria active enough to keep us well. So again, like you see the beneficial flora normal, but your short chain fatty acids low, I would still be thinking about using probiotics. I would certainly be thinking about upping all the fiber possible as well. But if we want to increase GLP-1, one of the best ways to do that is to increase your short chain fatty acids. And so And, this research went on to say, yep, this is why it's a target for diabetes. And we know that our GLP-1 agonists, of course, that's their on-label use. The off-label use is weight loss. And so GLP-1 does a lot of things for us, not just weight loss, neurogenesis, memory, helping in terms of lipolysis, helping in terms of making sure we don't have too much salt, improving vasodilation, moving glucose out of the periphery into the muscle where it won't do damage, where it can be converted into energy, improving beta cells to regulate insulin, and even helping us cardiovascular speaking. So there's a lot of benefit of GLP-1, which comes to us through from fiber, which is ultimately what is your level of short chain fatty acid. And so again, when we're dealing with someone with more cognitive decline and you're thinking, oh, brain fog, I bet they've got something dysbiotic. Yeah, maybe, but maybe they just aren't producing enough short chain fatty acids, because it turns out that we have receptors for various short chain fatty acids in our brain. They increase brain derived neurotrophic factor. And so like I used to, always talk about and still do, butyrate decreasing risk of colon cancer. But it turns out it also decreases risk of breast and prostate cancer, because we do absorb some of those short chain fatty acids, and they're anti-inflammatory. So other systemic cancers risk go down as well. Some fascinating data in terms of the subset of COVID long haul patients who have a particularly defining symptom of brain fog. So not the ones that are clotting a lot, not the ones that are necessarily fatigued, anxious, or depressed, but if brain fog is like the big debilitating symptom that still exists. Research went on to talk about how one of the things that happens with COVID is there's an upregulation of toll-like receptors on your gut cells. So the gut, basically antennas for inflammation go up. The gut becomes more likely to be inflamed. Zonulin goes up, as particularly in a subset of COVID patients with GI symptoms. That zonulin is absorbed, tells tight junctions to open, gives us leaky gut, but some is absorbed and is also active at the blood-brain barrier. Zonulin causes the blood-brain barrier to be leaky, and this research went on to say one of the major reasons for brain fog post-COVID is a leaky blood-brain barrier. So, not necessarily your dopamines and your epinephrine and your norepinephrine, and not necessarily the thyroid piece and these other things that we might often treat for brain fog, but in the case of COVID long-haul brain fog, a leaky blood-brain barrier. Then the research went on to say, and one of the best things to do about that is to make sure you have adequate short chain fatty acids, because the thing that competes with zonulin at your blood-brain barrier are your short chain fatty acids. And so even in brain fog, we're looking at these short chain fatty acids to gauge what our next steps should be. These short chain fatty acids have a lot of activity there. And I find this really clinically useful in another way too. How often have you sat back and you thought, ooh, I want to do some detox work with this patient? If I chelate, remove a metal, is there a risk that it will disassociate, cross the blood-brain barrier, and they could be worse off than they were before? Typically, the answer is no, because lowering body burden lowers body burden in the brain as well. There's some secondary things that we can do there that improve binding to your chelators, like N-acetylcysteine and alpha-lipoic acid, a whole nother topic. But if we're worried about those things crossing the blood-brain barrier, go to your stool test first. If they have good levels of short-chain fatty acids, then that will be competing with any zonulin at the blood-brain barrier. You've got a really kind of glued up blood-brain barrier at that point. And or make sure, if you're doing some chelating, that you're really stressing the high fiber, et cetera. It will help in terms of not having detox reaction, but it helps with the brain fog that can happen from that as well. So a lot of positive things about GLP-1. It's just there are ways to get there besides, just an injection. Our short chain fatty acids are a big example of that. And so acetate is one of them. So usually I'm jumping up and down about butyrate, decreasing risk of colon cancer, and that's true. But as I mentioned, acetate is one that shows up a lot in terms of, for example, cardiovascular literature. And acetate is another one that is able to cross the blood-brain barrier and is even found in all tissues in the body. So again, you know, fiber is not just for the gut. What starts in the gut doesn't stay in the gut, whether it's healthy or unhealthy. In this case, healthy pieces getting in as well. And so when acetate crosses the blood-brain barrier, it has a direct appetite suppressing role in the central nervous system. And so acetate also binds to G protein coupling receptors, GPR41 and 43. These are involved in signaling to increase that production of GLP-1. So we'll look at acetate because we see a lot of research in terms of helping us cardiovascular speaking. Acetate decreases cholesterol. It decreases absorption of that, or even production of that bacterial endotoxin that creates that metabolic endotoxemia. That metabolic endotoxemia is largely responsible for more aging, decreases inflammation like TNF alpha and NF kappa B. Okay, other short chain fatty acids. So again, there was no parasite, there was no yeast. What am I going to treat now? Plenty left to treat. Go to the short chain fatty acids. If propionate is low, this should be your second most abundant short chain fatty acid. And it is the main ligand for the receptor that increases production of GLP-1. In addition to that, it increases leptin. So we want some leptin. It makes us feel full. Think of it kind of like insulin, but when we've triggered it and triggered it and triggered it, we get leptin resistance, and then our brain doesn't signal feeling full anymore. So it's that, you know, just like insulin, you wouldn't want it too high or too low. So it's that managed leptin. And then when propionate is low, we'll kick into gluconeogenesis in the liver, and cardiovascular disease increases. Propionate, when it's low, you'll have poor tight junction function. So it's connected with a lot of autoimmunity. And you can see it high. And so this can always be a confusing thing. So, okay, this is a short chain fatty acid. We want more of it. You just told me about GLP-1 and all these things it does. But what about when it's high? How much of a concern is that? Well, the reason that that's a concern is because if it's way out of balance, you're not looking normal anymore, and it can be indicative of an imbalance of flora that's making more propionate at the expense of other things. And so it's not per se that the propionate is bad, it's that it's telling you about an imbalanced microbiome that's associated possibly with things like autism or methylation issues, or even obesity. So butyrate is the one that's absorbed least from the intestine, actually. And so it mainly acts locally there at the colonocytes. Lovely anti-inflammatory activity for colonocytes. So again, you're a chronic IBS patient, but no bacteria there, but the butyrate is low. I mean, this is really the thing that nourishes those colonocytes to calm down. It will help the division of cells that has to happen every 3 days, and it can also prevent cancer as well. So when it's low, that's a concern in terms of our tight junctions and changes in terms of things like insulin secretion. So back, you know, when, what is this, 5, 6, 7, 10 years ago, I don't know, somewhere back there. But what we saw was diet drinks, of course, no question in my mind that they weren't good for us. No question about the neurotoxicity. But when we began to see those studies about diet drinks also increase diabetes, I was like, okay, that's weird to me, because I get all the neurotoxicity part, no problem there. But at least like the one thing is it shouldn't cause diabetes, because what's diabetes? It's sugar, it's carbohydrates, it's therefore more insulin, it's insulin resistance. So why would it still do this as well? And what we went on to learn, what we found out was that diet drinks influence the microbiome. They kill off flora that are producing more butyrate, and butyrate has an influence on appropriate insulin secretion. So there you are on your diet drink trying to not get diabetes. diabetes, and it too is a risk factor. So again, just love how this information can really pull the picture together for our patient. You've got someone whose gut just always hurts no matter what they do. Really hone in on that butyrate, because when it's there, this is one of the things that signals more mucus production. And the research just says, you know, your IBD, your IBS patient, they come to planet Earth often with just a thinner lining right there at the gut. And this is why just, you know, whatever it is, almost any kind of protein, any kind of little perturbance and negatively influences them, because that lining is thinner. So when you're trying to just build the thickness of that, more mucin and everything, just so people feel better, butyrate is a go-to for that. So valerate's the one that comes from amino acids, so it can tell you a little bit about your protein status too. The others are more carbohydrates. And so, yes, butyrate or short chain fatty acids are not just for colon cancer. And so while it is true that they are major signaling molecules, they don't just stop there. Yes, they do signal more colonic blood flow and more electrolyte uptake and proliferation of the mucosal lining there. But like I mentioned, we do absorb some as well. And those short chain fatty acids, or maybe even if you're not absorbing them directly, those short chain fatty acids cause more release of various peptides and GLP-1, which cause us to feel more satiated and behavioral change. So this moves from the gut lining to the brain to say, okay, now you feel full. And so these short chain fatty acids increase the expression and the secretion of GLP-1. So really, one more check in the box for fiber in terms of weight loss. And I mean, how many people come in and say, I can't lose weight? And then when you look at their fiber intake, you know, 5 grams, 7 grams. I mean, count the grams of fiber in the next salad that you eat. Just while you're there, just pull up the various things. You're going to be blown away. That salad only has like 3 to 5 grams of fiber, maybe, unless you're putting an artichoke heart on it or something like that. So like, it's shocking. You can be eating a pretty healthy diet. Like I was one who's like, I eat vegetables at every meal, even breakfast. I must have fabulous fiber. Well, when I really was tracking it, I was like, ooh, 15 grams, 18 grams. I was for sure. I was like hitting 30 every day. No, you're not. I mean, you've got to really be working on it. You've got to really be thinking about it. So those people come in, they say, I've done everything to lose weight. You go back to the short chain fatty acids. If they're low, you know, there's not necessarily a reason to jump to exogenous GLP-1 yet. You haven't done everything you can to really influence your own endogenous GLP-1 at that point. And so, like I mentioned, receptors in the central nervous system in terms of short chain fatty acids. So they will cause more increased biogenesis, increasing brain-derived neurotropic factor. So keeping our brain nice and young as well. And so here, the looking at, for example, more when we're looking at those with gut permeability, that's decreased by more of the short chain fatty acid producing bacteria. So again, just helping to make that point in terms of connectivity. So these lipopolysaccharides, they also cross the blood-brain barrier, but when you see them high in circulation, they only create an issue cognitively 60% of the time. Well, so what's going on in the other 40% of the population? If I'm dumping a toxin into the body, wouldn't we expect that it should have a relatively similar effect on most people? And in fact, the answer to that is no, because I could have a decent amount of LPS, but if I'm cramming that fiber in, really increasing my short chain fatty acids, they are going to block LPS at the blood-brain barrier. And this is another reason that I'm going to end up feeling better. So when we're kind of thinking about, okay, what do I want to eyeball on my stool test for my autoimmune patients? You want to be really super, super picky about all of your short chain fatty acids. Why? Because they directly increase signaling for your Treg cells. And those are the ones that put the immune system back in balance. Those are the ones that compete with that more inflammatory Th2 or that super inflammatory Th17 response. This is the one that was upregulated in COVID. This is the one that's responsible for that cytokine storm. This is also upregulated by yeast. So, when we see that like a little bit of yeast on a stool test and you're wondering, is it worth treating? Is the person highly inflamed? Are we looking for every way to tone down immune inflammation? If so, then running them through a course of something that will, follow the premise of first do no harm, like some caprylic acid or oregano oil. Yeah, and this Th17 branch, it's not just COVID, it's rheumatoid arthritis that it's upregulated in, IBD that it's upregulated in. You can see it increased in various cardiovascular disease like atherosclerosis. So if we want to have a huge anti-inflammatory effect, and again, nothing dysbiotic, nothing to kill, but your short chain fatty acids were low, this will mean that your immune system is out of balance. Bacteroides, some of your beneficial flora, this also, alongside lactobacillus and bifidobacter, decrease your T cell activation, and really, that secretory IgA. Yes, we always say, it's 85% of the immune system, but I would argue that it might even be more than that. Because if your secretory IgA is low, IL-10 is low. And IL-10, for example, is in breast milk. And IL-10 is the one that sends the signal that says, hey, don't react to everything. See this as normal. For example, if you're doing desensitization, either oral, sublingually, or through the skin, the whole mechanism of action there is that it increases this IL-10, and then other things increase IL-10 besides desensitization as well. Probiotics do that. This is why that study with lactobacillus was largely so favorable. Omega-3s do this as well, and so they'll increase your amount of IL-10 to say quit reacting to everything. Well, if secretory IgA is low, you're not making a lot of IL-10. Your body is going, oh my God, react to everything. Why does the body do that? Well, if your 85% of your immune system is down, if your first line response is down, then that sends a signal to the rest of the bodies that says, oh my gosh, we do not have a lot of protection here. The rest of the immune system better stay upregulated, on high alert. And you see this in many places, but you see this with food sensitivities all the time. Somebody has really high IgG reactions, you get them off foods, you do some things, and they're like, oh, I really want to redo that test. I want to see what things I can eat now. You do a follow-up test, and the titers are still elevated, but they came off the food. Why would that be? Again, this is a great time not to keep repeating food tests, but go back to your stool test. What does the microbiome look like? What does secretory IgA look like? If it is low, it sends a signal to the rest of the immune system to say, ramp up. First line defense is down. We need protection. Increase IgG, increase IgE, and be more reactive to things that are out there. In fact, research talks about if secretory IgA is low, you will treat your commensal flora in a totally different way, right? That's another clinically confusing one too. I got this commensal flora here. I don't know. It's not a pathogen. It can be, usually normal. Is it enough to drive pathology in this patient? And one of the things that really cranks up the impact of that commensal flora is the level of secretory IgA. If it's low IL-10, the body goes, what is offending my immune system? What has knocked it down so much? I don't know. There's no pathogens. Maybe it's this commensal stuff. Let's launch an attack to it. So now in the world of low secretory IgA, you will create much more oxidative burst to commensal flora. You'll begin to recognize them as pathogens because the body's like, what is it that's knocking us down here? I'm going to take more offense at these things that I might normally consider normal. So these things are all really important to hone in on because not only making us not react to foods and not react to the world around us. I mean, those fragile patients, from mold to foods to, chronic illness in terms of infections, they just get reactive to everything. But again, a hallmark of autoimmunity is lowered Treg function. So if I want to put the immune system back in balance, I want to focus on things to increase Treg cells. And that means going to my stool test, looking at my short chain fatty acids, thinking about my bacteria, thinking about things like secretory IgA. And so here we're looking at other functions from the other things that are made. So, okay, benefit to short chain fatty acids, but also some long chain fatty acids that are made that can also do things like increase GLP-1, do things like helping produce various fats, and so activating various vitamins. So a lot of important activity from our microbiome. And so here is, again, just an example of what our bacteria is doing, but you see acetate increasing your Treg cells, as does propionate. Interesting, tryptophan does that too, not 5-HTP, but tryptophan has some unique mechanism of action in the gut, different than some of its metabolites. If you've ever seen some research that's distinct from 5-HTP and wondered why, it's because it has different activity in the gut there. So again, really, when we think about what's building our tight junctions, we're back to our short chain fatty acids. So they're highly protective. They improve Treg function. And so if we want to have more healthy aging in general, then the idea is, yeah, let's not let even those commensal get too far out of range, and let's make sure that diversity is really good, and doing things that are anti-inflammatory, like improving those short chain fatty acids. So again, the schematic is just really nice in terms of how it shows, ooh, okay, more short chain fatty acid that comes down into a gut cell. It decreases any production of inflammasomes. It sends signal to improve integrity of the gut lining. And so all this diversity, sending similar signals, nice diversity, increasing your Treg cell versus, okay, no short chain fatty acid. They just even work as physical blocks. So now when there's more of them, you're blocking some of this LPS coming through. So now more bacterial byproduct, bacteria itself begins to leak through intact. You're going to activate that naive T cell, and you're off to the inflammatory races. So we know that allergies are getting worse and worse. And so this is that study I was talking about. I think I said 84%. So 82% were tolerant, but only 4% when you did not think about the microbiome at the same time. Sometimes, you might have a kiddo who's just super suffering from eczema, and you're just thinking, oh, well, maybe I'll just send them to a standard allergist. Maybe that would be a better outcome. And I would argue that anytime you're combining gut microbiome work with those desensitization strategies, you are going to have much more positive outcomes. So highly improved activity there. Our short chain fatty acids decreasing sensitivity, our good healthy bacteria decreasing reactivity as well. And so when we look at a young gut versus an older gut, we see more of this Akkermansia beginning to take over. Now, it takes over from Bifidobacter, has a lot of anti-aging capacity to it. We hear about it being associated with a lean diet and with lean phenotypes, but yet sometimes you see it high. And so, wait, she said it was associated with anti-aging. What do I do when I see it high? Do I treat it? Do I knock it down? And while there are some elevations, higher levels that are associated with things like Parkinson's in the research, I think what we're going to learn, what we're going to find out is that it's not that Akkermansia is causing Parkinson's. There's too much favorable data to really come to that conclusion, but that it probably goes up in response to inflammation to try to deal with that inflammatory load that is occurring, kind of like TGF-beta and mold. It goes up to calm the immune system down. It's not like mold makes TGF-beta and TGF-beta is bad. No, really, it's trying to calm down an overactive immune system. It tells us about the mold story. I think we'll learn a similar thing here, but I would still try to work to bring the microbiome back in balance. So the more Bifidobacter, the more we can reverse aging, but the Akkermansia does a similar thing for us as well. And of course, well, this is beautiful, not seeing a lot of pathogens. And like I mentioned, when we start to see lower level of yeast, well, how Th17 driven is the person, because yeast will push that, increasing the importance of treating it. So we know Akkermansia is associated with a leaner phenotype and less diabetes. And so in general, we think of it as being beneficial. But again, you can see this sometimes. What do we make of that? Again, it's probably going up in response to some inflammation. Now figuring out what the inflammatory impetus is our goal, rather than killing it. And so here's some of those studies that talk about, yep, it's not just a consequence of aging, but when we treat it, when we increase bifidobacter by giving it, you see a downregulation in TNF alpha and various inflammasomes and things that push chronic conditions and aging. And this schematic's a little complicated, but what you'll see is if we find our favorite things like Akkermansia or butyrate, the red means it pushes it in a negative direction, and the gray means that let me make sure I'm saying that right. And the gray means that it's stopping it. So gray, stopping inflammation, stopping DNA damage, a lack of butyrate causing more insulin resistance. Our Akkermansia here, if we follow it down, preventing cognitive decline. And so all these things that are associated with aging, cancers, cardiovascular disease, are quite traceable back to different gut microbiome types. So I mentioned how anti-inflammatory short-chain fatty acids are. There they are, increasing our Treg function, putting our immune system back in balance. And when they're low, more candida can take over for that reason as well. And so this is why we ramp probiotics when we're in a flare, because it will cause less inflammation, and it will even cause more T lymphocytes to undergo apoptosis, and it helps to even move short chain fatty acids into the cell itself to act in a less inflammatory way. So, I guess it's kind of obvious how to check butyrate. There's our butyrate, but eyeball the pH as well. And so if that's high, it's not really about digestive enzymes. When this is high, it tends to mean that you have low butyrate producing bacteria. So even if this looked okay, but this one were high, it's not enough to maintain this person's pH like they should. And so it should still be looked at. So our immune system becomes upregulated and pushes chronic inflammation when we're more permeable, when there's a poor microbiome, when immune cells become overactive, and when there's a decrease of things like Treg cells, poor adrenal function, and poor histamine degradation. And so we'll utilize various flora that are protective from our allergens. We'll look for patterns that can cause more histamine or autoimmunity. And we'll look to even some strain-specific choices in terms of decreasing things that are histaminergic. So I want to go ahead and stop there. Maybe I'll have to come back and do a part 2. So let me go ahead and stop there so I can make sure that we get to all of our questions. I'll leave you with let me say 2 things first. If you enjoyed some of this teaching, go check out Origins Incubator. I wrote the clinical curriculum, but it is a practice management mentorship, and we mentor you legally. I work with Scott Radigan. He's a lawyer who specializes in integrative medicine. I work with Dr. Linda Mattioli, and she is a doc who had a waiting list in 6 months. So we just give you an EMR, we give you a storefront, we teach the method that she used for a waiting list, we talk about how to price things, we do all the legal part, and then I'm there teaching the clinical. And so we do a lot of discussion in terms of this stool test and comparison to other stool tests out there, because in my opinion, this one is the only one that's going to give you everything you need to see, which is both culture and sensitivity, but also the PCR information. So you're seeing all the species, but still getting an idea of what's clinically meaningful. And we dive into all of that in terms of how to put together more gut-based approaches. And so it's a year-long mentorship designed to get you up to pace in 6 months from basics to launch. But we also work with people that have been in the integrative space for decades that are just looking to fine-tune things. So I'll leave you with this and I'll open it for questions. This poem from Shel Silverstein always reminds me of the microbiome. So like I mentioned, when we come onto the planet Earth, we have very little bifidobacter and we work to get more, which slows the progression of aging. But as we leave the planet, we have less bifidobacter too. So just like the boy who dropped a spoon and the man who does too, and the boy who wets his pants and the little old man too, and the boy who cries often and the little old man too, and the boy with no bifidobacter and the little old man too. So he said, you know what? Held his wrinkled old hand and he said, I know what you mean. So I think it's a sweet poem, and it also brings to mind it's all about our microbiome and what they're doing as well. So with that, Dr. Ferris, I'll let you guide us through some questions.